Hi, I'm Dr. Glen Iannucci, a pediatric cardiologist at Children's Healthcare of Atlanta and director of the Aorta and Vascular Clinic there. And on behalf of the GenTAC Alliance, I'll be presenting a review of some pediatric activity guidelines. So one thing I would say is that in thinking about the potential risks related to activity, we should also think about the potential risk related to exercise restriction. These are some slides that have been put together by the CDC that show overall rates of obesity in the United States. So this is what things looked like in 1990, with many states experiencing a 10 to 14% risk. This is in 2011. You can see now many yellow states with a 25 to 30% rate. And 2015, things are looking a little worse, mostly orange with 30 to 35%. And the most recent data available from 2021 is now showing pretty significant coverage with 35 to 40%. So we know that there is significant risk to inactivity. So in thinking about who needs restriction and who doesn't, I think we need to be mindful of that as well. Why should we be active? Originally, the goal was survival. So, several decades ago, really the main goal was trying to get people to be able to live long, because the mortality rates were hard and it was harder to think in a longer term picture. Now the goal really is optimization, living well. Current mortality of Marfan syndrome approaches the general population. So how can we improve the quality of life, not just the duration? We know physical activity and moderate doses does reduce the risk of developing hypertension later, which we know is a clear risk factor for aortic dissection in adulthood. So it's very possible there could be a happy medium in terms of exercise for our patients. In the United States, the most recent guidelines were released in 2015 and regard the eligibility and disqualification guidelines for competitive athletes with cardiovascular abnormalities. And really, within the document, they do point out that this tends to apply mostly to individuals between the ages of 12 and 25. They do point out that these recommendations should not be regarded as a general overriding rule against all forms of exercise. Rather, that this is only concerned with organized and sanctioned competitive sports, such as those in middle school, high school, college, and not with recreational activities. And I think that's a very important note. These guidelines classify sports based on increasing dynamic or static component of the sport itself. And for patients with Marfan syndrome, they note that you may participate in 1A, class 1A here, and class 2A. If there is no aortic dilatation or history of early dissection, and certainly no severe LV dysfunction. For Loeys-Dietz, vascular Ehlers-Danlos, and other heritable conditions, the participation allowances are similar. They do recommend against all contact sports as well. Additionally, the Marfan Foundation has provided activity guidelines, which really note that moderate activity is probably the peak that would be ideal for patients who have Marfan syndrome. They recommend avoiding exertion at levels greater than 6 metabolic equivalents. In 2020, the European Society of Cardiology released guidelines for sports participation in those with cardiovascular disease. In particular, they have this rather concise table for patients with aortic disease. And overall, the overall nature of their guidelines tend to be a little bit more permissive than the guidelines that were published by the US groups in 2015. Particularly for patients who have a bicuspid aortic valve, you can see that participation is in general allowed until you get to more substantial aortic dilatation. Additionally, for patients with Marfan syndrome, they are not excluded from some of the endurance sports they would be allowed to participate in. It does make the comment that they should avoid contact sports as well. So in general, when we are restricting individuals from activity, that is to help them to avoid an aortic event or perhaps disease progression, we know aortic dissection is a very rare event. In fact, the IRAD registry showed about 2 to 3 per 100,000. And in the pediatric side in particular, we know that the rates of dissection are much lower. In fact, for a study that looked at all hospitalized children in Texas over the course of 7 years, that incidence was about 3 out of 100,000 hospitalized children, so not children that were at home. 24% of those patients had connective tissue disorders, and only 5 of the patients had dissection at the time of presentation. All of the other events were a complication related to a procedure. So if we were to extrapolate, presume the incidence of connective tissue disorder was 1 in 5,000 of the 3.9 hospitalized children, then there would be 780 patients with connective tissue disorders, and 5 of those had an event. So that's a 0.6% risk of aortic dissection prior to admission for patients who were sick enough to be hospitalized. And none of those patients were under the age of 13. For comparison purposes, when we think about risk, the risk of dying in a car accident is about 0.9%. And as we've reviewed, much of the guidelines that have been generated are really with adults in mind. There are no pediatric specific activity guidelines. There is a recent excellent review of the available literature that was completed by Dr. Shepard and Dr. Braverman. That's referenced there. The overall risk of aortic vent in childhood is low, even for those with HTAAD. This paper in particular looked at Marfan syndrome. Risk of events does increase with age and size of the aorta. One thing to note, however, is that the physiologic effects of sports involvement in young children, in many cases, may only be minimally different from routine childhood play. This is one of my children who was on this bouncy toy at a playground, and this was at the start, and after 5 minutes was quite red in the face and breathing very hard. So it might not be appropriate to exclude children that are very young from routine sporting activities that may or may not involve much vigor. Bearing that in mind, our group put together a proposed physical activity guidance for children with HTAAD. This is not published anywhere. This has not been endorsed by any societies, but just kind of a framework to help us to discuss with families. I would say that, obviously this needs to be taken in the context of each patient specifically. There's a lot of data on this slide or recommendations. We included something about amusement parks as well, because this is a question that is clinically frequently encountered. I get asked this all the time, and I cannot find any real data to support a statement one way or the other. So in general, this is what our group tends to allow. Certainly as individuals approach the teenage and adolescent years, particularly with the increasing intensity of sports around that age, we do end up aligning with the guidelines put forth by both the European Society and the American Heart Association and the Marfan Foundation.